Okay, so welcome to the second edition of Knowledge Series from Fortis Institute of Blood Disorder. And as we know, AML still remains an unconquered thing in India. If you see any national registry, you see lung cancer, you see breast cancer, you see head and neck cancers. Of course, those are the major priority areas for a country like us. But we also have to realize now in this country you have hematologists who can treat definitively hematological malignancies with great success. And it will be no way now we know that blood cancers had got the highest number or highest cure rates in the world. But still, that remains unconquered. And we have none other than Dr. Jayastu, who has been in the thick and thin from CMC Vellore to All India Institute of Medical Sciences and now to MD Anderson, who has written a beautiful commentary about the challenges of treatment of AML in India. And who else better can tell us, because he has seen both the world from the number values as well as from a cutting edge work which MD Anderson does, which is like innovator in the world. And all of us, though Venetoclax is still not being approved, it will still take 6 months to come to India, and we're all getting Venetoclax across the world. Who else other than Jayastu can let us know how to treat these people? Because now we know that days of 7+3 might be numbered. So I'll be tempted to ask questions. Can we write the obituary of 7+3? Are there only subset where only 7+3 work and not azacytidine and venetoclax? And under the able leadership and the collaboration of all the departmental people, right from Dr. Nikhil to Dr. Chitresh, who was our AML and ALS specialist, along with Dr. Anusha, Dr. Richa, who's a geneticist, Akash, who's the geriatrics, along with Dr. Neha, who's an ID specialist, a combined team at Fortis is now entering into with Dr. Srinidhi Nathani, spearheading the precision NGS, which can give us the results within 42 hours to 72 hours. So we will be all tempted to ask, can this precision medicine be taken to the bedside and get away from 7+3? Is what Jayesh is going to tell us in next 30-35 minutes. So stay tuned. Over to Dr. Nikhil, who has been spearheading this and whose brainchild is to bring to the practical aspects of what can be done in India, because from a speakers of star information can be transferred to Indian population so as to better manage this. So over to Dr. Nikhil and Dr. Jayasu, thanks for being there. It will be wonderful. We keep on interacting, and thanks in advance for imparting the knowledge of what you have earned through your hard work and consistent effort over these many years. Over to you, Dr. Nikhil.
It's a privilege and honor to introduce Dr. Jayastu Senapati, who was my senior from AIMS and a dear friend. Dr. Senapati received his MD in internal medicine from CMC Vellore, followed by his DM hematology training from AIMS New Delhi. He went on to complete his leukemia fellowship from MD Anderson Cancer Center, Houston, Texas. His research interest includes drug development in myeloid malignancies, and he's actively involved in many clinical trials exploring the impact of genetic mutations in AML patients, as well as developing clinical protocols for patients with high-risk mutations like TP53 mutated AMLs. He has several peer-reviewed publications in both international reputed journals, and he has written many comprehensive reviews discussing the evolving treatment paradigm in AML patients. He is also a recipient of numerous accolades and prestigious awards, including the ASCO Conquer Cancer Merit Award consecutively in 2022 and 23, as well as the ASH Abstract Achievement Awards for 22-23. Over to you, Dr. Jayastu. It's my privilege to introduce you, and we would like to hear from you regarding how can we use azacytidine and venetoclax in our setting, considering the high prevalence of infections and many other problems that we face in our setting. Can this be used as a frontline regimen? How best to utilize this effective strategy for our Indian patients? We would like to hear from Dr. Jayastu. Over to you, Dr. Jayastu.
Thank you, Nikhil and Dr. Bhargav. I hope I'm audible.
Yes, you are.
Right. First of all, thank you for considering me for this talk. This talk and this topic is very close to my heart. Thank you to Dr. Bhargav for his very kind introduction. I hear a lot about your work from India, very challenging situations, despite which you are able to do very high volume, complicated transplants. I know a lot of Southeast Asian patients uh, go to Fortis Institute of Blood Disorders for their tertiary care hematological needs. And personally, also, we have had patients who have been from the Southeast Asian countries who have not been able to do transplant in the United States, opt to go to Fortis. I know personally a couple of patients who have been at MD Anderson. This is very inspiring to see, and I'm sure this is just the beginning of a wonderful future. I know you have a wonderful team now. Nikhil, who was my junior, very hardworking, resilient, and very knowledge-thirsty hematologist, and your entire team of staff at Fortis Institute of Blood Disorders. Thank you for considering me for this talk. Feel free to stop me anytime. I would like to make this a very fluent and like a discussion rather than a narrative. And at any point there is any snag, Nikhil, you know how to contact me so that I can stop there and restart. Are my screens visible? No, I have to share the screen, I guess. Just give me 1 second. Nikhil, are my screen visible? Is my screen visible?
Yes, it is. Please go ahead.
Okay, wonderful. So today's topic is optimal use of Venetoclax and Azacytidine in AML. And as we know, this is not a very unidirectional topic because the choice of a low intensity versus an intensive therapy in AML is a very dynamic choice. A patient might not be eligible for intensive therapy today, but in 7 days of good internal medicine support, infectious disease, or critical care support, his condition might improve. And you might think, hey, this patient who was not amenable for intensive therapy now seems amenable for intensive therapy at this point, and even a stem cell transplant possibly in due course. So it's a very dynamic condition, it's a very dynamic decision, and dissecting the nuances of this decision is what I will try to do during this talk. So feel free to stop me anytime. I have no relevant disclosures to the talk. The talking points, I want to be very clear at the beginning itself. Nikhil had sent me a bunch of questions, around 54 questions to be precise. I have not gone through them point-wise, but I hope my talk would address majority of them. And then during the discussion session, I can address few of the other talks. So I'll speak a little bit about Venetoclax, primarily focusing on the biology, conditions in which Venetoclax is poised to work better, and situations where the use of Venetoclax is debatable. How can we look beyond HMA-VEN? HMA-VEN has been the crux of therapy in older unfit patients and even in younger patients in India, where resources are limited to some settings. And we did see that in during the COVID time as well. What is the ideal low intensity combination in such settings? What are the do's and don'ts of Venetoclax? What are the situations in which you would consider reducing the duration of Venetoclax? What are the different settings you would use Venetoclax? Those would be the talking points for today. Right. So Dr. Bhargav alluded to this paper that we wrote. It came in, at the drop of a hat that there should be something that, makes the hematology world in India, address some of these specific challenges. So we went about writing this small commentary in Lancet Hematology that was very well received, understanding where are the areas where there needs to be more investment from healthcare, from policymakers, etc. And then what are the areas in which we have made some progress as it is? Dr. Bhargav just mentioned that Venetoclax is still not routinely available in India, and it's really something to ponder about. A country of 1.4 billion people, and we are still missing out on approved Venetoclax. But I understand a lot of patients are still able to use it, but the quality of such Venetoclax remains debatable. So it's indeed very important that Venetoclax comes to the formulary in India. It is available almost in 80% of the world now, and India is called the pharmacy of the world. So it's surprising why Venetoclax has not permeated its boundaries as of yet.
Jestu,
Now,
I'm sorry to interrupt you. Can you make your presentation full screen?
okay.
Your slides are visible, but it's not
I
full
got it.
screen.
I got it. Just 1 second. Is it full screen now? No?
Not yet.
Now?
Yeah, perfect.
Okay, all good?
Yeah, great.
Perfect. Right. So while we speak a little bit about the social, situations that define AML care in India in the previous slide, I will now delve more into the biology of Venetoclax. I think before we go into that, it is important to understand the situations in LMICs where acute myeloid leukemia care is done. I would refer to the paper by Chep C. Phillip when he was at Christian Medical College, Vellore, that got published in British Journal of Hematology around 10 years ago that looked at infections, including invasive mycosis of over 25 to 30% in the frontline settings in patients with newly diagnosed AML, and that presumably holds true today. Of course, we now have prophylactic azole antifungals, which has been a game changer in places like India where there is a high incidence of invasive mycosis. Collaborative groups like Hematology Cancer Consortium are working towards identifying the risks of these infections in the frontline settings, and it would go a long way to set some benchmark on which further studies could be done. And I understand that Dr. Bhargav's group is also working on that. Now, the Venetoclax story actually started a long time ago, 2016. This paper was published in Cancer Discovery, led by Dr. Marina Konopleva. Unfortunately, as a single agent, the drug didn't fare well, leading to only 19% objective response rates. But this was before the time frame when the biology of Venetoclax was drawn out, and it took a few years for researchers to understand that in myeloid cells, all Venetoclax does is reduces the apoptotic threshold of the cells, and then something that actually actively kills the cell needs to be added to it for accruing the maximum benefit. Now, this is slightly different from what it is in CLL, where Venetoclax as a single agent also is effective. In myeloid leukemia cells, the action of Venetoclax is as a combination, and this is very important when defining and designing clinical trials as well as standard of care therapy. When you're trying to reduce the duration of Venetoclax, the period that you will not touch is the period where there is the combination of the drug with the backbone, whether that be intensive therapy, lodocytarabine, or hypomethylating agent. Because Venetoclax alone does not cause myeloid leukemic cell death, but it reduces the apoptotic threshold, and then HMA or whichever is the backbone that you use leads to the cell death. Lo and behold, this was studied in two randomized controlled trials. One of the most cited papers was the Viale-A trial led by MD Anderson, Dr. Courtney DiNardo, that led to improvement in response rates as well as relapse-free and overall survival, leading to the approval of this drug in the particular setting in which the study was done, that is older unfit patients. Now, important to remember the cutoff of patients in Viale-A trial was 75 years of age. Younger patients could be included if they were deemed unfit based on their performance status and based on ongoing infections. The VLAC trial looked at the same thing but with lodocytarabine. Possibly the success of the combination was not as great, as a result of which lodocytarabine with Venetoclax combination has kind of fallen out of practice, and it's mostly an HMA combination for low intensity therapy. Now, though this is not the crux of the talk, I just wanted to highlight that as proof of concept that Venetoclax works well with everything, there have been two frontline ongoing trials, the FLAG-IDA with Venetoclax and the CLIA with Venetoclax at MD Anderson. And this was a very nice propensity score analysis of patients treated with intensive therapy plus Venetoclax compared to those patients who had received intensive therapy in the previous era at MD Anderson. And of course, we showed better overall survival, event-free survival, and improved response rate with Venetoclax combination, just to show that the addition of Venetoclax to backbone therapy, whether it be HMA or whether it be intensive therapy, leads to improvement in outcomes. Now, Venetoclax has become the bread and butter of hematologists, not only those who treat AML, but ALL, CLL, MDS, MPN to some extent. And a lot of other fields are also looking at the benefit of Venetoclax. But it is important to understand in myeloid neoplasms what are the exact biological subsets of patients where Venetoclax is poised to work. So different groups have looked at this. This was the exploratory analysis from the Viale-A trial. And as you can see, Venetoclax seemed to be working well both for de novo and secondary AML. It did work well for patients with NPM1 IDH mutation, but in patients with adverse cytogenetics, patients with FLT3, particularly FLT3 ITD, and in those with TP53, the addition of Venetoclax to an azacitidine backbone did not per se lead to any significant reduction in the hazards of death. This is extremely important because this was the first snippet that showed us what are the determinants of response, resistance, and chances of progression after venetoclax-based therapy. Now, the first green oval over here looks at de novo versus secondary AML. Now, as more and more patients are living longer, more and more humans are living longer, you will see more and more secondary AML, which could be clinically defined secondary AML. That means patients who have had a prior diagnosis of MDS or CMML who progress to AML, or patients who do not have anything, presents clinically de novo, but has secondary group of mutations or myelodysplasia related changes. We are going to see that way and way more often because people are living longer. And lo and behold, Venetoclax does work well in this situation. And that has been a lot of my personal work as well, which I will show here. Now, Venetoclax has become the standard of care now with azacitidine as an FDA approved as well as European Medicine Agency approved. We spoke a little bit about the determinants of response. Almost all patients respond well to a Venetoclax combination, but TP53 mutation and maybe FLT3 ITD, and I will dive a little bit deeper into this. So this was the first paper that looked specifically at the genetic subgroups of disease where patients who received HMA plus venetoclax had a prolonged remission, which could be the group A. These are patients primarily who had IDH1, IDH2, mutations like DNMT3 and ASXL1. Then there were patients who responded but then relapsed, that is group B. These are patients who, of course, had TP53, some FLT3 ITDs here and there, lesser frequency of IDH1, IDH2, NPM1. And then the primary refractory, which are again patients enriched with adverse cytogenetics and TP53. This is a very important figure for anyone who deals with venetoclax to remember. Now, looking at specific subgroups, I will not go into details of it because I presume this audience already knows it. But NPM1 mutated AML, of course, remains one of the best friends for venetoclax. Very good response rates. This is again an exploratory analysis from our group led by Curtis Lakowitz and Dr. DiNardo that showed the addition of venetoclax to an HMA-based backbone when compared to intensive therapy or HMA alone in slightly older patients with NPM1 mutated AML. As you would imagine, venetoclax-based combination, the curve on the blue at top does the best. Now, similar data was also shown through exploratory and correlative analysis of the VIALE-A trial. This was data led by Daniel Polea from University of Colorado, and he very nicely showed that when you teased out the IDH group from the VIALE-A trial and the phase 1b trial of azacitidine venetoclax, the patients who actually did the best were those who had the IDH1 or 2 mutations, particularly the IDH1. If you split curve A into curve B and curve C, you do see that the IDH1 did very well with venetoclax-based regimen. The red is only azacitidine and the black is azacitidine plus venetoclax versus those who were IDH wild type. The difference was there, of course, but it was not as wide as it was for patients with IDH mutated AML. And as you see the response rates here also, IDH1 and IDH2 literally melts like butter in the presence of venetoclax. And for patients who have NPM1 or IDH mutated neoplasms, venetoclax-based therapies does wonderful. Now, of course, in India, you do not have ivosidenib and enacitinib. The situation gets a little complicated when you have them as well in the arsenal of drugs. Our approach is to use a triplet. Dr. DiNardo is leading an oral triplet of oral azacitidine or oral decitabine with venetoclax and an IDH inhibitor, and we have seen tremendously good response rates, but not to worry too much if you don't have the IDH inhibitors because HMA venetoclax combinations does exactly well enough. And of course, if you have younger patients with these mutated neoplasms, do not hesitate to add venetoclax to intensive therapy, which is either FLAG or 7+3 based on your practice preference. Now, we spoke about 2 specific groups where venetoclax is known to work very well. Now, what about secondary AML? 30% of patients, 40% of patients eventually will be those who have secondary AML, either clinical secondary AML or genomically secondary AML. Now, this is one of the most formidable papers in the last decade led by Eli Manuel, who tried to dissect the genetic heterogeneity of acute myeloid leukemia. And as you can see, the blue arrows look at those genomic aberrations, mutations-wise, as well as cytogenetics, which define the secondary type aberrations, which includes -7, ASXL1, TET2, splicing factor gene mutations that shows a secondary type mutation. And almost 30% of patients in this group had AML with some kind of secondary type aberrations, including TP53 mutations. This was the first paper that again tried to understand, are secondary group AML slightly different? And yes, these mutations which are highlighted on the top tried to coalesce more with clinical secondary AMLs, and now they have also been used by both the WHO and the ICC for classifying AML to be secondary-like, even if they have not had any prior history of myeloid neoplasms. Now, what is our approach for AML? So you could have patients who have therapy for non-myeloid cancers, develop MDS, then get therapy for their myeloid cancers, that's called treated secondary AML, and go to AML. We could have patients who get therapy for non-myeloid cancers and directly develop AML. Then there could be de novo patients who develop MDS, do not get therapy and get AML, which is untreated secondary. And lastly, are patients who have never had any history of prior other cancers or myeloid cancers and develop AML. So this is the clinical approach to secondary AML or de novo AML. Now, with the addition of this genetic data, we do know that a significant percentage of de novo AML could also have MDS-like genetics, and they are now called secondary AML. Therapy-related AML has always known to behave like secondary AML, and amongst the group of therapy-related AML, the most challenging population are treated secondary AML. These are patients who have MDS or CMML, they get low-dose Ara-C or hypomethylating agent, and they become AML. They are the toughest patients to treat. But eventually, what we are left with are true de novo AML, a very small subset of patients who really have not had any prior neoplasms that needed chemotherapy or radiotherapy, who have never developed MDS or CMML, and who do not have any of the secondary group aberrations. And now we are left with around 10 to 15% of AML. Now, to address that, in the latest iteration of the ELN risk stratification, the ELN added ASXL1, BCOR, and all those mutations I just alluded to in the adverse risk category. But this was probably done considering data in the non-Venetoclax era and in younger patients treated with intensive therapy. We know that the secondary group mutations are more common in older patients. These are patients who are 40 or 50 years and beyond. A lot of the times are treated with Venetoclax-based regimens in approved settings, but now everybody gets Venetoclax, right? So to address this, we have done some analysis to understand if truly these splicing factor gene mutations, which are present in a handsome percentage of population in acute myeloid leukemia, really benefit or do not benefit from Venetoclax-based therapies. So to understand this, we analyzed around 1,000 patients from MD Anderson with newly diagnosed AML. We stratified them based on the presence of splicing factor gene mutations. The most common splicing factor is SRSF2, as we know, and we had around 700 patients who were splicing factor wild type. Notably, there were no patients who had splicing factor gene mutation in the CBF group. We can talk a lot about the disease biology of it, but that's not the crux of today's talk. So we know that CBF AMLs do not have splicing factor gene mutations. Overall, the patients who had splicing factor gene mutations had higher frequency of TP53, ASXL1, and 1X1, because of which they were more commonly adverse. Now, majority of the patients in our group, when we looked at their clinical stratification between de novo and secondary AML, we found that those who had splicing factor gene mutations, that's here, 51% of them had clinically secondary AML, but virtually now all of them are secondary AML because all of them have splicing factor gene mutations. In the splicing factor wild type, the frequency of clinically de novo AML was higher, which again attributes to our present knowledge of AML biology. Overall, there was no difference per se between the different type of splicing factor gene mutations. SRSF2 did slightly better, and responses of patients with or without splicing factor gene mutations were equivalent irrespective of whether they got intensive therapy with Venetoclax, and similarly with low intensity therapy. Now, it is important to see here that when we stratified patients based on their age and treatment, we do see that splicing factor gene mutated patients does exactly similar to patients who are wild type for splicing factor gene mutation. And when we look at only those patients in our cohort who received Venetoclax, we see that the addition of Venetoclax to low intensity therapy improved the outcomes of patients with splicing factor gene mutation and those who were wild type for splicing factor equivocally. In fact, if you look at the curve on the end, that is D, we do see that the addition of Ven to the splicing factor mutated one improved their outcomes more than what Venetoclax did to those who were splicing factor wild type. The p-value almost tends towards significance. Now, the primary reason why the ELN put splicing factor as adverse was because they were looking at data from intensively treated patients who did not receive Venetoclax. So when we looked at the survival outcomes of our younger cohort of patients who were treated with intensive therapy, indeed, those who had splicing factor gene mutations did slightly inferiorly. Then when we teased out from this group those patients who received Venetoclax and intensive therapy, we again see that the negative impact of splicing factor gene mutations goes away and patients behave similarly irrespective of the presence or absence of these mutations. When we went ahead and did some logistic regression and Cox proportional hazard model, we actually found that in older patients treated with intensive therapy, splicing factor gene mutations does better, so does Venetoclax. So again, this completely revokes the ELN's concept of splicing factor gene mutations being more adverse in the face of Venetoclax-based therapies. And to cut the talk short, patients who have splicing factor gene mutations, and to even extrapolate that, all secondary group mutations like TET2, ASXL1, DNMT3, and splicing factor gene mutations, Venetoclax works really well in these patients and is an ideal area where you would want to give splicing factor gene mutations with low intensity therapy if it's an older or unfit patient, and with intensive therapy if it's a younger patient. Now, parallelly to this study of ours, there were biological work done by Omar Abdelwahab Sloan Kettering, who showed that the presence of splicing factor gene mutations actually induces Venetoclax sensitivity, and a lot of groups are looking into that. Now, in high-risk MDS, which behaves a lot like AML, also, Venetoclax does really well if you have splicing factor gene mutations, chromatin modifiers like ASXL1, EZH2, and doesn't do well in the presence of complex cytogenetics. I just wanted to show this figure because I know a lot of patients are getting Venetoclax-based therapies with HMA in high-risk MDS as well. Now, this wonderful paper by Nasima Gangat from Mayo Clinic also looked at those areas where Venetoclax-based therapies does better than non-Venetoclax-based therapy. And as you can see in A6L1, SRSF2, IDH, and TET2 groups, the use of Venetoclax improves the amount of response or remission that you get. But in TP53, the story is far from true. So that brings me to the next point. Where does Venetoclax not work? So till now, we have seen that Venetoclax works well in NPM1, IDH1 or 2, presence of secondary gene mutations. But of course, there have to be places where Venetoclax doesn't work. That brings us to TP53 aberrations. And all of us who treat AML know that this is possibly the most challenging area. And in these group of patients, the survival have really not budged over the last 20 years. This exploratory analysis from the Viale-A trial showed that the addition of Venetoclax did improve the response rates in patients with poor risk cytogenetics with or without TP53 aberrations, but the improvement in survival was not very significant in TP53 mutated patients. To understand this question in greater granularity, we have been leading this study for some time. This manuscript is almost ready and should go out any time. We looked at the entire cohort of patients with newly diagnosed AML at MD Anderson, and we divided these patients into monoallelic TP53 and biallelic TP53 and tried to understand what is the use of Venetoclax in these group of patients. And as you can see here, Venetoclax did improve the response rates to an extent. So this is the full AML cohort with TP53 aberrations. The CRC rates were 54% with Venetoclax, 40% without Venetoclax. the overall response rates were higher as well. In patients with high-risk TP53, which is essentially biallelic TP53 or one TP53 mutation with a chromosome 17 loss, again, venetoclax improved the response rates, but these were not significant or good remissions. That means though the patient responded, these response durations were very short. This did not lead to higher rates of transplant in venetoclax-treated patients. And as you can see in the curves on the right, the addition of venetoclax did not improve survival compared to patients who did not receive venetoclax, both in the full AML cohort, that means anyone with TP53, or AML with high volume TP53 or high burden TP53 mutation. So unfortunately, venetoclax has failed in a very important subset of AML. Now, I did mention that secondary AMLs with all these mutations, I mentioned just now, venetoclax works really well. But remember, not all secondary AMLs are the same. I mentioned to you before in the flow chart, the treated secondary AMLs, which are patients who have MDS or CMML, then they get HMA, and then they become AML. They are, again, equally challenging situations like TP53 AML. Again, to understand this question, we led this study with over 1,500 patients newly diagnosed at MD Anderson. We had 1,200 patients with de novo AML, 352 patients with secondary untreated. This means these are patients who have CMML or MDS. They get either just, erythropoietin type of agents or hydroxyurea, but never received hypomethylating agents. Then we had 717 patients who received hypomethylating agents and then became AML, and therapy-related AML who had therapy for non-myeloid cancers. And as you can see, that patients have higher frequencies of TP53 aberrations when they are secondary AMLs. They have more complex cytogenetics. But of importance is the histogram here that shows the treated secondary AML, the response rate are extremely dismal, 25% overall response rates or CRC rates. And this is much lesser compared to what we see in de novo AML or secondary untreated AML. But even more dismal is to see their survival outcomes. Treated secondary AML, irrespective of their age, which means whether you use low intensity therapy or intensive therapy, 2-year survival is just 7% in older patients and just 14% in younger patients, almost mimicking what we have seen with high allelic TP53 aberrations. We again tried to tease out, does giving venetoclax in patients with treated secondary AML matter? So we looked at response rates. Yes, the response rates were slightly better in the venetoclax group than in the no venetoclax group. In fact, it was statistically significant, but this improved response rates were not clinically meaningful improvement in response rates, and thus the survivals did not improve in treated secondary AML when they received venetoclax. Now, it warrants that we tease out the use of venetoclax based on prior exposure to venetoclax. As you can see, 13% and 9% patients in our cohort had received venetoclax before the onset of their AML, because a lot of our MDS and CMML patients get venetoclax. The data of those who did not receive venetoclax is not shown in this figure, but we will have it in the manuscript. And again, even in these patients, the addition of venetoclax does not help. Now, NPM1 mutations are, of course, one of the best mutations to have for a patient with newly diagnosed AML, and there is conflicting data. What happens if NPM1 mutated AMLs have secondary group mutations? So there is 2 studies came out very recently. One on the left is from ASH, that was an abstract, and they looked at patients who had NPM1 with secondary group mutations, and they showed that when you treat them intensively, it doesn't matter. And the right is the paper that just came out in Blood Advances, and they looked at patients who had NPM1 mutation and all these mutations treated on regimens which were either intensive and low intensity, and they found that the good impact of NPM1 is lost when these secondary mutations are present. Now, in our Blood paper published last year, we do look at this population briefly, and we do see that NPM1 mutated patients, when they have secondary group mutations, when you give them venetoclax, they do as well. Both these studies have not been done stratifying outcomes based on exposure to venetoclax. So I can say almost confidently, of course, we are looking at better data, that NPM1 mutated AMLs, even if they have other secondary group mutations, they do really well with venetoclax-based regimens. Of course, if they have TP53, etc., then that's not true. Now, to understand all these issues, the ELN has tried to propose this new risk stratification in AML, going away from the old ELN 2022 stratification. The 2022 stratification does not consider the use of venetoclax, the newer one does. And with the use of venetoclax, we see that only the presence of TP53, ITD, and the RAS mutations matter. Patients who do not have these mutations do the best. Patients who have these mutations do the worst. So if you have a patient with TP53 mutation, and I would focus primarily on TP53 and FLT3 ITD, you would not want to give them possibly venetoclax, but alternative regimens. And if you have other mutations, you should go ahead and give them venetoclax-based therapy, provided they are not treated secondary AML. Now, looking beyond HMA-VEN, and I think this is something that Nikhil asked me to focus on, the long follow-up data from azacitidine venetoclax is dismal, 14.7 month survival. So what can we do beyond this? As a result of which, we started this phase 2 trial led by Dr. Tapan Kade in our group. That is a very novel method. We have used a lot FLAG-IDA. I know a lot of people in India also use that. That's a dual nucleoside, fludarabine and cytarabine. Could we use that technique in a low intensity setting? And to do that, we use cladribine followed along with low-dose cytarabine and venetoclax first 2 cycles, and then we alternate HMA-VEN and cladribine low-dose Ara-C-VEN. This is our ongoing phase 2 trial. This is our frontline mutation agnostic therapy, and we have seen fantastic results. This is the last publication from GCU, and I know that Dr. Kade is working on updating that. These are mostly older patients with median age of 68 years, and you do see that at around 2 years time point, the disease-free survival is at 60%, which was unheard of in the past. In the recent update of this from ASH last year, we saw 75% true CR rates in patients around 70 years of age. The 2-year overall survival was 65% and median OS was 50 months. So this is certainly much better from what the HMA venetoclax showed. And this is a regimen that could be used more widely in conditions like in India, where there are high risks of induction deaths from infections, because this regimen uses the benefit of dual nucleoside, alternates with HMA-VEN, and gives the benefit of both worlds, while allowing patients to proceed towards consolidative allogeneic stem cell transplantation if required. Now, consolidating these patients after low intensity therapy or venetoclax. A lot of the times we have younger patients. I know this is very common again back in India and other high infection burden settings. A patient comes in sick. You have to put them into remission, control their infection, and then what? Do you take them to transplant? Do you give them intensive chemotherapy? Or do you just continue the low intensity therapy? Well, you should not continue low intensity therapy, because you do not want a 30-year-old patient to keep getting HMA venetoclax forever, because eventually the disease will relapse. So you either take them to transplant or you consolidate them. Well, since this study was geared to patients only more than 60 years, we looked at this analysis in which we took patients who were more than 60 years in MD Anderson, who received clad-LDAC-VEN and then proceeded to transplant, and compared their outcomes to, again, patients more than 60 years of age who proceeded to transplant after intensive therapy or HMA-VEN-based therapy. Now, at MD Anderson, our cutoff for transplant is 75. Majority of patients up to 70 get transplant. Our highest transplanted patient is 79 years of age. So a lot of patients beyond 60 years of age go to transplant. And HMA-VEN is actually approved for beyond 75 years. So though in India, we do not give intensive therapy after 60 years, a lot of the world still try to give attenuated doses intensive therapy beyond 60 years. So what we try to understand is whether survival of patients who get clad-LDAC-VEN-based therapy and then go to transplant is different from those older patients who receive HMA-VEN-based therapy or intensive therapy and then go to transplant. So we compared around 40 patients in each group, pretty well-balanced groups. Again, response rates were 100% with clad-LDAC-VEN, so was it with intensive, and so was it with HMA-VEN. These are all patients who proceeded to transplant, so of course there is a selection bias. These are all patients who responded. Now, importantly, this is what I want to tease out. When patients who received clad-LDAC-VEN and they proceeded to transplant, the 3-year relapse-free survival from diagnosis was 81%, compared to 60% for intensive and 31% for HMA-VEN-based. The 3-year OS was equally promising, 84% versus 41%. When you have data like this, it becomes very difficult to put down a regimen like cladeldagbin, even in patients who are due for imminent stem cell transplantation. When we look at patients who had adverse cytogenetics or TP53 mutation, again, we do see that patients who went to transplant after cladeldagbin did slightly better than patients who received intensive therapy or HMA-based therapy and then proceeded to transplant. The cumulative incidence of relapse and cumulative incidence of non-relapse mortality, especially the CIR, was also lower for cladeldagbin than intensive therapy. And both the CIR and non-relapse mortality was lower for cladeldagbin compared to HMA. This paper should come out hopefully next week, and further details will be in the publication. Now, does therapy intensity matter in non-CBF AML? Possibly not. If you're taking the patient for consolidative stem cell transplantation, if they're MRD negative. This was a retrospective analysis done by my colleague Alexandre Bazinet, and he showed that those patients who reach MRD negative and then they proceed to transplant or whatever type of therapy, it does not matter how you became MRD negative. If you became MRD negative after low intensity therapy and venetoclax, or if you became negative after intensive therapy, your outcomes were mostly similar. Now, this is possibly true for patients who are going to transplant. But in patients who are not going to transplant, I think it's premature to say that giving a patient 30 years of age or 40 years of age low intensity therapy forever is going to lead to similar survival outcomes. Now, coming to FLT3 mutated AML, this is important because in India now you have midostaurin, sorafenib, and I understand gilteritinib is getting approved or launched soon. Now, is HMA-VEN a good option in FLT3-ITD AML? Well, no. This was an analysis from MD Anderson that showed again that when you add HMA plus VEN to FLT3 mutated AML, though the responses are slightly better, 68% versus 46%, the survival aren't. Patients with FLT3-ITD AML did as good with HMA as they did with HMA-VEN, and this was the era where the FLT3 inhibitors were just coming into the forefront. And I already showed you in the determination of response study by Dr. Donato that FLT3-ITD patients were one of those who did not do really well with HMA venetoclax as an exploratory analysis of the VIALE-A trial. So to understand this question, we have been leading several phase 2 clinical trials of triplets with this an HMA plus venetoclax plus FLT3 inhibitor. So if you have to have a drug bear the load of therapy in these conditions, it has to be the FLT3 inhibitor. So this paper led by Dr. Nick Short just came out, 30 patients in the frontline cohort, and we see 100% CRC rates and CR rates of 90% when patients were treated with azacitidine, venetoclax, and gilteritinib. Look at the median age, 71 years, with 97% patients more than 60 years of age, a population which is at high risk for infections, yet did very well with these therapies. Now, the reason why I'm emphasizing on this is because a lot of morbidity in a patient at the time of diagnosis of leukemia is from the leukemia. Infections come because the patient has leukemia. Nutrition is poor because the patient has leukemia. Deconditioning happens because the patient has leukemia. So all guns should be pointed towards the leukemia. Of course, the therapy cannot be super toxic that the infection takes over the body, but the best way to get the patient better is to lead to a quicker remission and give maximum support during the initial phase of therapy. And that's why triplet low-intensity regimens are the way to go in FLT3 mutated AMLs. The median overall survival was not reached, and 1 year and 18-month survival was both over 75%, and this is wonderful outcomes in these settings. Of course, infections are the most common, but grade 5 infections, there was just one. I understand these might be higher in India, and those need to be shown in prospective studies. If you have to choose between a doublet, that is an HMA versus plus FLT3 inhibitor, versus a triplet, what would you do? So in the previous study of Aza and Gilt, I showed that the triplet did better. But to understand this question, Yilmaz led a retrospective analysis and showed that with triplets, HMA, Ven, FLT3, both the CR, CRI, PCR negativity rates were much higher. And survival, of course, was improved in patients who received a triplet compared to doublet. The time to count recovery, especially in the first cycle, was slightly tardy in those who received a triplet than a doublet. Now, how to combat that? Now, the way to combat that is to play with the dosing of the drug. And I think this is a very good slide to remember. In cycle 1, where you need remission and you want to point all your guns towards therapy, try to give as much regimen as possible without compromising care. So give 7 days of Vidaza and 5 days of Azacytidine. Give 14 days of FLT3 inhibitor, 14 days of Venetoclax. Do a bone marrow at day 14. If the patient has frank disease or more than 10%, 5% blasts, continue the Venetoclax for again 7 to 14 days and continue the FLT3 inhibitor. But if the patient marrow becomes empty at day 14, you can stop everything, and that would reduce the duration of cytopenia during cycle 1. For subsequent cycles, do not play too much with the dose and duration of the FLT3 inhibitor. As I mentioned, the majority of the work here is being done by the FLT3 inhibitors. Reduce the duration of the HMAs. You could do 5 or 3 days of DAC, 5 or 7 days of Vidaza. Reduce the Venetoclax to 7 days, but continue the FLT3 inhibitor. Maybe reduce the dose of FLT3 inhibitor if required, but the FLT3 inhibitor is what suppresses the clone, and it's better to do the best it can. Okay. Now we have 4 FLT3 inhibitors, and yesterday in JCO, the crenolanib study led by Eunice Wang just came out. The phase 3 of crenolanib versus midostaurin is going on. So it's difficult to say what is the best FLT3 inhibitor. Certainly quizartinib has shown improvement compared to midostaurin as part of the Quantum Force trial that just came out. Gilteritinib is, of course, approved in the relapse refractory setting, but we personally at MD Anderson use gilteritinib and quizartinib. We do not use midostaurin because we feel that these are better FLT3 inhibitors. And now data from Spain and other groups have shown that quizartinib also has efficacy in FLT3 wild-type AML, but this is a matter of time before it can be used for clinical practice. Now, addressing practice issues with HMFN, this is going to be the last part of the talk. As you can see, even in the Western world, in a phase 3 clinical trial, 72% patients with receiving HMFN had to have a dose interruption, and almost a quarter of patients had to have dose discontinuation during the VIALE-A trial. In patients who received more than 2 cycles of therapy, 60% of patients had a cycle delay, even amongst those who received CR/CRh. So despite HMA and Venetoclax being very friendly in young unfit patients or old fit or unfit patients, there is still some amount of cytopenia, some amount of toxicity, and it is important to combat that, especially in places like India where induction mortality could be 5 to 10%, and a lot of patients have incipient fungal pneumonia or endemic tuberculosis. But as part of a small analysis from the VIALE-A, they were the first to show again that those patients who received 21 days of Venetoclax versus 28 days of Venetoclax, which was the VIALE-A design, there was no difference in outcome, though the study was not powered to look at that. Now, we are trying to understand more and more about how much we can reduce the Venetoclax. I'm sure all of you who use Venetoclax in India do not use it for 28 days because we have learned our lessons during the early days of Venetoclax, the profound cytopenia 28 days could cause. So in induction, you're probably using 14 or 21 days, and in consolidation, you're possibly using 7 or 14 days. So this was an interesting study just shown at ASH last year from 7 centers in France. In patients who were 75 years of age, median age is 75 years, they gave just 7 days of Venetoclax. And even with that, 49% patient had febrile neutropenia. Time to count recovery was not too bad. 51% patient had delay in cycle 2 initiation, but reasonably good response rate, 68%. And in real world settings, OS of 12.8 months with HMA Venetoclax, not a bad outcome after all, looking at the median age of 75 years. So this is very early data to show that reducing the duration of Venetoclax to 7 days might be a very worthy option. Now, the Mayo Group also did a retrospective analysis of their patients, and they compared those who received 7 days Venetoclax versus 21 days and 28 days, and showed that there is no real difference in outcome by reducing the duration of Venetoclax. Now, while I say this, I will go back to my first opening statement that patients who receive Venetoclax, the duration that they're receiving in combination with their backbone agent is the most important. So if you're reducing the duration of Venetoclax, reduce it distally, not proximally. Now, to answer some questions, Nikhil had sent me 54 questions. Difficult to do all of that, but I hope my talk has already answered some. And I'd quickly take some of the other questions. How long do we give Venetoclax? So in cycle 1, it's usually 21 days. We do a bone marrow at around 14 days, especially in older patients or those who are sick with infections, etc., to assess the disease status. Now, I have been at AIMS, I have been at Vellore, and have seen both sides. Our patients here cannot be compared to what patients were in India. A lot of them are very sick, very infected, very debilitated at the time that they are presenting. So in these patients, it's worthwhile to do maybe just 7 days of Venetoclax. After CR, the duration of Venetoclax is variable. We do give for a 7 to 14 days, but it depends on age, fitness, risks of baseline infection, and cytopenia in previous cycles. For dose modification, first reduce duration, then reduce dose. Don't compromise Ven during the period of combination therapy, which I've reiterated 2 to 3 times in this talk, and always aim to start Venetoclax with HMA concurrently. I know it's difficult in India to do that, but if you start Venetoclax after you have finished HMA, probably the Venetoclax is not doing much because it is reducing the apoptotic threshold, but there is nothing to actually kill the cells. How do we titrate the dose of Venetoclax with azoles? During the ramp up, we give echinocandins, and then once we have attained the 400 milligram dose, we drop the dose depending on what antifungal we are using. Remember, CYP3 inducers increase metabolism of Venetoclax, so in these situations, you have to increase the dose. I don't know if ivosidenib is being used in India, but to remember that when you're using ivosidenib, the dose of Venetoclax should be 600 milligrams, which gives an actual dose of 400. So I have already gone into how we plan our bone marrows and everything, so I would not delve into too much detail for that. This was a study that was done by one of our wonderful pharmacists who looked at the use of an azole antifungal and what happens in those patients who receive Venetoclax with azole antifungal, and found that the time to platelet recovery was longer in those who received azoles with antifungals. How do we consolidate a CR attained with HMA-Ven? Of course, if the patient needs transplant based on initial genomics, should consolidate with transplant. Now we have enough evidence that once deep remission is attained, that is more important than what therapy you have attained to use the transplant. Can we consolidate with intensive therapy? We have had a lot of discussions about this. In fact, there is no study as of now that looks at the outcome of patients who received HMA-Ven in induction and thereafter were consolidated with intensive chemotherapy. And I think India is an ideal setting to generate such data. What about fit young patients? Always prefer intensive chemotherapy. There is a phase 3 RCT being led by Dana-Farber, Dr. Amir Fathi, who is looking at HMA-Ven to intensive therapy in all comers. And that data will tell us if HMA-Ven is good. We have completely let out 7+3, but I think as of now, it is still too early. For patients with FLT3 AML, CBF AML, RAS mutated, RAS is very sensitive to cytarabine. NPM1 and IDH always choose intensive therapy. For CBF AML, Venetoclax is possibly not a good option. Use gemtuzumab if available. We always use flag-based therapy with gemtuzumab. If you cannot do intensive flag-based therapy, then you can do cladribine with low-dose cytarabine and add gemtuzumab. Biallelic TP53 aberrations, I already showed limited role of intensive chemotherapy and Venetoclax. If you have a patient with low VAV TP53, let's say less than 20%, with no complex karyotype, use Venetoclax. But with biallelic, that means more than 40% TP53 mutation or a low VAV mutation plus chromosome 17 loss or complex karyotype, I don't think Venetoclax does much. But if you have a transplant awaiting for this patient and you think some form of marrow remission is important and you can immediately transplant, then do give Venetoclax even in these patients, because I showed that response rates are increased with Venetoclax. Treated secondary AML, again, the role of Venetoclax is limited. You can try intensive chemotherapy with Venetoclax if you're going to do transplant, but if you're not going to do transplant, you might just as well do HMA-based therapy. MECOM rearranged AML, I would still say that they're very high risk, very poor outcomes, but possibly limited role of Venetoclax. In unfit young patients, I would want to choose clad-LDAC-Ven over HMA-Ven because of the increased depth of CR/CRi and the data that I have now shown, which shows that once they go to transplant, their outcomes are better than when they receive HMA-Ven and go to transplant. Always prioritize adding FLT3 inhibitor to HMA-Ven if there is FLT3 ITD disease. Old unfit patients, I want to say that nobody is old enough. It's the physician who thinks the patient is old. Cutoff for alloSCD is provider dependent. For our patients, we use clad-LDAC-Ven and then keep doing clad-LDAC-Ven as long as the patient could tolerate. Once the patient is in remission, you can reduce the dose of clad-LDAC-Ven and HMA-Ven and continue it. You can even space the cycles out to 4 to 6 weeks, but keep continuing to do that. If the patient has a FLT3 disease, then add FLT3 inhibitor to HMA-Ven, and eventually you can just put the patient on FLT3 maintenance. CBF-AML in older patients, as I mentioned, clad-LDAC-Go or HMA-Go is better than Venetoclax. At MD Anderson for CBF-AML, do flag-based therapy with gemtuzumab, which has shown better outcomes than flag-based therapy with idarubicin, but I understand gemtuzumab is very costly in India, so that's going to be an open take. For FLT3 TKD, HMA-Ven is reasonable option. If TKD is at high allelic risk, can consider triplet with FLT3 inhibitor. With intensive chemotherapy, choose Venetoclax over FLT3 inhibitor. Progression after HMA-Ven is a very bad situation. Wait for 2 cycles at least before you call failure or progression. If a patient progresses after HMA-Ven and is a young fit patient, consider giving some intensive therapy and transplant in marrow remission. Maintenance settings, of course, there's a lot of scope for improvement here. If the patient has FLT3 ITD, give FLT3-based maintenance therapy. If the patient is mutation agnostic, you could do low doses of azacitidine for 3 to 5 days, or venetoclax for 3 to 5 days, maybe every 6 weeks for 12 months, could be done even in post-transplant settings if the patient does not have GVHD and have adequate counts. This is the first study of its type that looked at low-intensity maintenance therapy with HMA and venetoclax, and we have shown very good outcomes in high-risk patients who were given this maintenance. This paper just came out. As you can see, the dose is very low, and you can even reduce the dose and duration further in such situations. Decitabine alone could also be used as maintenance therapy. This was a paper published a couple of years ago in CBF settings where we showed that the use of decitabine in those who remain PCR positive or unable to receive full cycles of intensive therapy reduces the time or increases the time to morphological relapse or prevents relapse altogether. So what is our approach at MD Anderson? Hypomethylating agent monotherapy, of course, is one of the best ones that could be done because it's mutation agnostic. We try to add venetoclax whenever feasible to hypomethylating agent. If a patient has FLT3 ITD or TKD, and those ITD or TKD was persistent before transplant after, always better to give this type of inhibitor. In India, you have Honoreg, so Honoreg plus venetoclax could be a completely oral maintenance therapy option. Now, this was the paper again, which I showed at the beginning, but I was very pleasantly surprised when someone actually wrote a response to this, mentioning changing the paradigm of AML care in India. This is the type of discussion we would love to have to see how we could collaborate, gather data, show the world how things are improving. And again, from humble beginnings to a glorious future, I'm sure India is poised for greater glory. We have done so much in space and everything. It's time now for leukemia care and cancer care. So in summary, I think I've gone through most of the points that Nikhil has, but before I take too much time, I'm going to leave some time for the discussions, and happy to take any questions. You can reach me at these email address or on Twitter.
Thank you, Jayestu. That was an excellent talk. You covered the topic comprehensively. You answered most of the questions that we had. The lucidity and clarity with which you explained the concept and addressed all the practical issues for all of us who use azacitidine venetoclax routinely, it was just great. It was wonderful listening to you. I have quite a few questions which I've received from my colleagues and during the webinar. I'll try to cover most of them.
Could I see those questions, or you will tell me?
I'll tell you. I'll tell you.
Okay, okay.
So to start off, a question from my side. You presented very interesting data regarding how clad LDAC-Ven patients did better post-transplant when compared to patients who received HMA-Ven. That data was very interesting. But in both the subgroups, what was the MRD status before taking them up for transplant?
Majority were negative. Of course, majority were negative. Now, remember, when we are looking at MRD negativity, there is no limit below which we can say for sure that there is no disease, right? At the time of leukemia diagnosis, you might have 10 to the power of 13 cells. At the time of MRD negative, you have 10 to the power of 7 or 8 cells. So there is still burden of disease, which we are not able to detect. And I think a lot of work from Dr. Chris Hurigan's group has shown that any MRD below 10 to the power of minus 4, let's say by using FLT3 ITG, ddPCRs, or NPM1, it predicts relapse, right? So though HMA-VEN is also causing MRD negative at a level of detection of 10 to the power minus 4, so is clad-LDAC-VEN. Possibly the quality of the MRD negative remissions are even better with clad-LDAC-VEN. And there might be some other alterations in the bone marrow microenvironment. That's why even when you transplant both these groups, the outcomes are better in the first.
And to extrapolate this, does this difference apply to patients who become MRD negative with intensive chemotherapy versus patients who become MRD negative with HMA-VEN? Does the quality of MRD differ in these groups also?
It would be exploratory and it would be a little, premature for me to say because I don't have the data or I didn't show that yet. But I'm sure if you're looking at 10 to the power of minus 6 level of MRD, you'd probably see some MRD hovering around in patients with FLT3 and NPM if you are treating them with HMA-VEN just a couple of cycles and then taking them to transplant. Whereas patients whom you're treating with intensive therapy and Venetoclax and taking them to transplant, maybe it's gone. But then I do not know that answer yet, right? Now, if you have to choose a low intensity therapy, what I can say is if you have to choose a low intensity therapy in a patient you're going to take to transplant, choose clad-LDAC-VEN and transplant rather than HMA-VEN and transplant. We have also seen that there is epigenetic priming that happens with the clad-LDAC-VEN. So remember, the clad-LDAC-VEN is not just clad-LDAC-VEN. It's clad-LDAC-VEN alternating with HMA-VEN. That's the regimen, and I showed that. So when you do that, there is epigenetic priming, there is exposure to dual nucleosides. So you are addressing several subclones of the disease. Remember, AML is very subclonal. There are many clones that's happening. If you're able to get rid of the biggest clone, maybe the smaller one does not create too much trouble. But if you're not able, but if you're able to clean up majority of the clones, even the smaller ones, then your chance of relapse also reduces, right? A lot of these times we are seeing patients relapsing. It's the subclone that's evolving that did not respond to Venetoclax in the beginning. But when you're using a wider array of therapy like clad-LDAC-VEN and HMA-VEN combined, you're removing majority of the subclones and possibly that's why your relapse is reduced. This is just hypothetical, but that's what we think is happening.
Great. That's very interesting. But what is the number of cycles that you would recommend prior to taking up a patient for transplant on clad-LDAC-VEN?
If you have a patient, I would do a couple of cycles at least. So when a patient comes to you, you give the regimen, you see the response. By the time you get the donor search done and everything, you will need 2 cycles. The first 2 cycles are clad-LDAC-VEN. I was talking with CMC Vellore, and I know that they are planning to do a trial. They were saying that to make the patients exposed to HMA-VEN, instead of doing 2 cycles of clad-LDAC-VEN, can I do 1 cycle clad-LDAC-VEN and HMA-VEN? The alternation starts from cycle 3 onwards if you look at the protocol. So that is an open question. Nobody knows the answer to it. But a couple of cycles of these type of regimens are good enough. And it will essentially temporarily also, you will need 2 cycles before you can take to transplant. Very difficult, maybe in Germany because they do the maximum transplants and they are able to do transplants very quickly. But for the rest of the world, it takes at least a couple of months before transplant is ready. So 2 cycles. If you are an MRD negative remission, further waiting might not be of use.
So very often we are faced with these challenges in real life clinical practice where we give HMA when patient has a huge disease burden, but let's say we finish 1 or 2 cycles and patients are down to 6 to 7% blast, or sometimes patients are in morphological remission, but they are MRD positive.
Correct.
What in your opinion would be the best approach forward? Should we continue HMA when, because assuming that we have to take them off for a transplant, should we continue HMA when since they have responded very well? Or if they have slightly increased 7-8% blast, should we switch to something like high-dose cytarabine?
Right. So first of all, it would be a statement of contention, but don't do HMA-VEN alone. Do clad-LDAC-VEN. You will see less of these situations. But of course, you could still have some situations like this. Now, the deeper the response before transplant, the better the outcome. There is absolutely no debate about this in AML now. In ALL, that debate was long answered. In AML, there was some debate, but now that debate is gone, right? So if you have to get a patient to transplant and you have hovering disease over there, you have given 2 cycles of HMA-Ven, 6 to 8% blasts. You can try a third cycle of HMA-Ven, but I doubt it's going to erase the residual leukemia. In such situations, changing gears would be important. So if you have not done Cladeldag-Ven, do Cladeldag-Ven. Or if you think you can do intensive therapy, then you do HIDAC plus Venetoclax, or 5 plus 2 plus Venetoclax, or FLAG plus Venetoclax. Why not that? Do not give anthracycline if you're worried. Just do FLAG and Venetoclax, and then take to transplant. So you're again giving a dual nucleoside intensive therapy with Venetoclax, and I presume after 2 cycles, the patient's fitness would have improved, infections would have been addressed, patient is more poised to get some better therapy. You give the FLAG plus Venetoclax, you wait for around 21 days, do a bone marrow, see no evidence of disease, get adequate nucleated events and say MRD is negative. If it's a completely empty bone marrow, you don't know. But if you have enough events with some cellularity, you know that you have done majority of the leukemia clearance, and then you take them to transplant.
So in our practice also, we follow a very similar approach. Patients who have responded well, but they have MRD positivity or let's say 6 to 8% blast, we usually consolidate with a FLAG ven and then take them for a transplant.
That's the way to go. Yeah.
Many other questions. Very often we defer Venetoclax because patient has an active infection, fungal pneumonia. But does it really make sense to not use Venetoclax because
No,
that's
you saw that part, right? I think that we discussed this a few days ago over the phone as well. It's a very important point. I have seen that in India also. So why do patients not get Venetoclax in India? One is procurement. Hospitals don't have a supply of Venetoclax. But I think a big center like your group, with of course Dr. Bhargav's leadership, you could have some stocks of Venetoclax just to bypass the first 7 days. I think that could be a good way to do what we do at MD Anderson. Before the company supplies us the drug, we have stocks in our formulary so that we can give it immediately rather than waiting. The combination period is supremely important. Let's say you want a patient to be treated with HMA Venetoclax, but the Venetoclax comes on day 8. So you've given HMA without Venetoclax. I don't know if the Venetoclax does anything after that. The majority of the Venetoclax work is in combination with the second agent. You give it later, you're missing out on efficacy. So then you're exposing the cells. So the BCL2 pathway is getting suppressed. So the cells which are resistant to that inhibition are getting populated, and you're actually inducing resistance to an extent. You see what I'm saying? So do not compromise. Keep a stockpile of Venetoclax for the first cycle before patients can arrange for subsequent cycles. And again, fungal pneumonia, the reason patient has fungal pneumonia is the leukemia. It's a do or die situation. Absolutely. The best therapy is the frontline therapy. The earlier you can get neutrophil recovery, the best. If you're worried about duration of cytopenia, remember the duration of cytopenia is going to be longer, more commonly from leukemia than the drug. Give 7 to 10 days of Venetoclax. Do not compromise on that.
Right. So that is,
if a patient is in ICU and intubated, then it's a different question.
But more often than not, we should go ahead with the combination therapy because ultimately that's what makes the difference. Rather than starting Venetoclax later, if we are giving it, we should give it upfront.
Absolutely.
Many of the patients, especially even if they are unfit elderly patients, they might present with hyperleukocytosis or a high WBC counts. Now, the initial prescribing information for Venetoclax says we should get down the counts and then start it. But if we have facilities to monitor patient for TLS, can Venetoclax be used as an effective cytoreductive agent? And should we really wait to get down the counts before we start Venetoclax? So what do you follow in your practice?
So we always wait to reduce the counts. We do not start Venetoclax before the WBCs are 20 or 30,000 because of risks of tumor lysis syndrome, renal injury. You get renal failure, that's it. Your entire therapy has to stop. So we do hydroxyurea, we do even cytarabine, flat dose of 500 milligram per meter square, 1 gram per meter square, and steroids. All patients of hyperleukocytosis, beyond 50,000, we do steroids, especially monocytic disease, because steroids reduce the inflammatory cascade. And in monocytic disease, it can even cause leukemic cell death. So we always do steroids with hydroxyurea or cytarabine, bring the counts down, and then do venetoclax. Remember, the microenvironment of the bone marrow is not friendly when you have hyperleukocytosis also. So beyond the risks of TLS, the efficacy of the drugs are also lesser when you have such hyperleukocytosis. So before you hit with the main regimen, cytoreduce.
So we need to always cytoreduce before we really start.
Yes.
But
With
again,
venetoclax
steroids
therapy,
with
yes.
because very often patients have an active infection. So steroids become a bit of a challenge. But I think getting the counts down with other alternatives definitely
Yeah.
does.
A lot of the times what we think is fungal infection here, at least in our group, and I know this is different for India, is actually leukemic infiltration of the lung. Patients who come with renal failure is actually lysozyme-induced renal injury in monocytic leukemias, and they do fantastic with steroids and cytarabine. So yeah, of course, it's a catch-22 situation, and the attending physician will have to decide.
So since we use azacytidine venetoclax extensively, in a few patients, we have seen patients developing pneumonitis, cardiac dysfunction with this combination. Do you also encounter these complications with HMA-VEN?
I know there was a recent paper again by Nasima Gangat and Alu Teferi. I think it came out in AGH or BCJ just a couple of weeks ago about venetoclax-induced cardiac dysfunction. We would have treated over 2,000, 3,000 patients, AML, CLL, MDS, maybe even more. We have not really seen that signal. And even in the VLA trials, that signal was not specifically found.
So in your experience, what are the rates of MRD negativity that you would see with HMA-VEN alone?
So Dr. Kumar, actually, it's been a long time since we have used HMA-VEN. We don't use HMA-VEN after the VLA trial. We gave it away to the world, but then we stopped using it because we are now using clad LDAC-VEN or triplets. We hardly use HMA-VEN. The only situations where we would use HMA-VEN is a very sick patient we cannot put on a trial, or a patient who has TP53 and all that. Maybe we use HMA-VEN. With our triplets, which is HMA-VEN FLT3 inhibitor or HMA-VEN IDH inhibitors or HMA-VEN plus a novel agent like we were using magrolimab for TP53, also, of course, it did not work. Or, for clad LDAC-VEN for mutation agnostic therapy, we are seeing CRs above 80, 90% and MRD negativity above 75% to 80%.
So that's phenomenal.
Yeah.
But when you use triplets, do you face the issue of prolonged cytopenias with triplets?
We did. So it is learning on the go. So as I showed you in the figure in the paper by Daver in Blood Cancer Journal 2022, he has teased out very nicely how to balance the dose of the drugs. So if you're having a FLT3 ITD disease, prioritize FLT3 inhibitor over venetoclax. Let's say you cannot give a triplet, then give HMA and FLT3 inhibitor instead of venetoclax. But always try to do a triplet than a doublet. Give venetoclax for maybe 7 to 10 days in frontline. Give the FLT3 inhibitor for 14 days in cycle 1. But in subsequent cycles, in first cycle, you can always abate the risks of cytopenia. Patient are in the hospital, you're treating and all that. If a patient comes in too sick with fungal pneumonia and all, give HMA for 5 days, venetoclax for 7 days, and FLT3 inhibitor for 14 days in first cycle. In subsequent cycles, give 5 days of HMA, 5 to 7 days of venetoclax, but the FLT3 inhibitor, keep it continuous. Because remember, FLT3 is like a naughty kid in the room. It's always trying to do some trouble. You need someone to discipline him. And the FLT3 inhibitor is over there. So it needs to have good exposure to keep the FLT3 mutation under discipline. Otherwise, it'll become resistant.
That's a very good analogy. So contrary to the popular belief, it's actually important to increase the duration of FLT3 inhibitor and keep it continuous as much as possible.
Got it.
Now with midostaurin coming into the Indian market, Aza-Ven midostaurin with gilteritinib coming into the market, I think Aza-Ven with gilteritinib would be a feasible option for many of our patients.
I think as of now, that's the best option. Quizartinib, of course, is not in India. It's just got approved in US. Crenolanib study just came out yesterday. If you're following my channel, you'd see that I put out that paper. If you don't get gilteritinib, midostaurin is good enough. Give something. Don't just give HMA-VEN and FLT3 inhibitor. Something is better than nothing. Gilteritinib, I understand, is super costly. Indian rupees 9 lakhs per month or something. I don't know the exact figures. Of course, if there is a patient who can get it, please give, especially if you're planning to take the patient up for transplant thereafter. But if not, give midostaurin, not a bad option.
Right. And what would be the median duration of cytopenia that you would expect when we add, let's say, gilteritinib to this combination?
In our study for triplets, we saw neutropenia of around around 30 to 35 days in first cycle.
Right. And coming to the response assessment,
Yeah.
so typically once patients achieve a CR with Azaven, how often do you reassess the response, or how often would you do a bone marrow for these patients?
Sure. So that is very contingent upon what your long-term plan is. If it's a 75-year-old patient coming to me, I give HMA when I exhibit that the patient has had a good response. I might do a marrow after 6 months, 12 months. If it's a 20-year-old guy who came in with fungal pneumonia, he's in remission, the pneumonia is not getting better. I'm always worried he's going to relapse. I need to do something. So I might do every 3 months till the pneumonia is better and he goes to transplant. So it's very dependent on what's the long-term plan. And of course, at any time the patient's cytopenia is not improving, patient had good counts, but let's say from cycle 4 onwards, his neutropenia is taking 5 weeks to improve, thrombocytopenia is taking 6 weeks to improve, you're possibly looking at relapsed leukemia over there.
So very often we are faced with a situation where patients will end up cytopenic at day 28, day 30. So how much of a break can we give prior to the second cycle?
We
And
usually don't go beyond 6 weeks.
And how liberally do you use GCSF in this setting?
Very liberally. If the patient is in remission, blasts are less than 5%, there is absolutely no reason why we shouldn't use GCSF.
And I think you already mentioned this, but regarding head-to-head trials comparing Azaven with intensive chemo, is there any update available as of now?
No, not yet. Amir Fatih's trial is going on. It has not yet been read out.
Right. And since we use 3+7 very often, how do you think, what is the best way to combine Venetoclax with 3+7 induction?
Give at least 7 days of Venetoclax, those 7 days. First cycle, I would do actually 14 days of Venetoclax. I know with 3+7 itself in India was challenging. We
Right.
had, when I was in Vellore, 5% induction death. When we were in AIMS, maybe more, because obviously patients with AIMS had more infections, etc. Because a lot of the times they would come infected, referred from other places. But at least 7 days of Venetoclax, if not 14.
And interestingly, in patients now, considering we are using azacitidine upfront in many of the patients and they go for a transplant. So do such patients benefit from maintenance azacitidine post-transplant also?
So this, I remember this question was discussed. There is no specific answer to this situation. Prior exposure of AZA and use of AZA post-transplant as maintenance. But if you have a high-risk patient, let's say you have a biallelic TP53 young guy, you were able to bring that person into remission. You were some form of remission, maybe just a marrow remission, not MRD negative and all, just complete aplasia, you transplanted. We are looking at very inferior outcomes if you relapse. Just for the sake of that, I'm going to do some HMA post-transplant, maybe HMA Ven, because you never know. There's a lot of immunological changes that are happening in the bone marrow after that. If you have a situation where you have an IDH mutated disease or FLT3, then post-transplant, you can use those targeted inhibitors. Of course, you do not have IDH inhibitors in India, so you would use Venetoclax with HMA. But FLT3, I would certainly use FLT3 inhibitors alone as maintenance. The Morpho trial showed that that was beneficial.
And the other question that has come up is many patients have extramedullary disease, CNS disease. Does HMA, Ven, or other low-dose combination treatments work in these patients as well?
No, that's so I should have mentioned that's not a good situation for low intensity therapy because the penetration in extramedullary sites is very limited. So those are situations where you would certainly use some form of high dose RC. High dose RC for us is 1.5 gram per meter square for 3 to 5 days because beyond that dose, we have seen it does not really inhibit much of the cellular pathways. So, but some form of high dose RC is important for CNS leukemias and extramedullary disease.
And I know this may not hold much significance in the current context, but does HMA, Ven, have a different outcome and different morphological FAB subtypes like monocytic variant? Does that really make a difference?
Yeah, so you're right. So monocytic AMLs are some group where venetoclax has not done as well. They are more MCL1 dependent, but that is also dependent on the type of mutations they have, you know. So that's one group. Certainly, erythroid and megakaryocytic leukemia are more BCL-XL dependent. 90% of erythroid leukemias are anyways biallelic TP53, so also venetoclax doesn't work. A lot of the megakaryocytic AMLs, which is of course very rare in adult population, but they are also BCL-XL dependent. So those are areas where BCL-XL inhibitors are being developed. Uh, Monocytic AMLs have been shown to be more dependent on the MCL1 pathway instead of the BCL2. No drug yet approved for that because of cardiotoxicity risks. Some trial had to be stopped. But for monocytic, I would still take the bet of venetoclax and use it until and unless they have TP53, etc.
In
And
patients,
monocytic are also cytarabine sensitive. So if you have a monocytic young guy, give them some cytarabine, whether it be high dose Ara-C 7.3 or clad-LDAC rather than HMFN.
right. In those patients who are refractory or who progress on azacitidine venetoclax, what are the chances that they will respond to a decitabine-based regimen?
Very low. You could have anecdotal experiences, but that wouldn't prove the law. But that's not a practice that we do until and unless we are looking at palliation.
And is there any number of cycles that you would limit to, or is it an indefinite treatment when it comes to
Indefinite.
HMA-pen?
If you're not consolidating with anything, theoretically it is indefinite. More times than not, you would land into trouble, and then you would either reduce the dose, pace out the drugs, or pray.
And what is your experience with navitoclax? How would you combine with it any of
It's a
these?
painful topic to discuss, my friend. I was about to start a trial with navitoclax, but you know, last week the drug was pulled off for good. All the navitoclax trials have been stopped. We were just about to open a trial of navitoclax, and erythroid and megakaryocytic AML. Everything was done. And in post MPN AML, that is another area which is extremely high risk. Venetoclax doesn't work. They are all BCL-XL dependent. So we were about to start a trial. I was supposed to be the PI with Sloan Kettering and MD Anderson, but that got pulled off because the company that makes navitoclax has decided to stop the development of the drug.
So in case we have to adjust the dose of venetoclax, is it better to reduce the duration or is it better to reduce the dose? Which one would you
First duration, then dose.
Perfect. And I mean, this question, I think, holds a lot of relevance in the Indian setting. Many of the patients might have a concurrent tuberculosis for which they might be getting ATT. So in such a setting, how well can we use venetoclax because they'll be getting rifampicin
You
and
know, this
that we have to
that's
give
that's a
venetoclax.
that's a study I think that your pharmacology team or your pharmacy team should do, because the venetoclax pharmacokinetics with rifampicin, you know, the drug you're worried about is rifampicin,
Absolutely.
and that's a drug you would not want to omit in tuberculosis
Exactly.
therapy also. So
That's
with rifampicin and venetoclax, the interactions are not very well known. Of course, rifampicin is known to increase the metabolism. So whether you would use a 600 milligram dose to get 400 or what, we do not know that, and that would need good pharmacokinetic studies from places like India.
so with
But
doc
let's say if you would want to use venetoclax, at least do 400 milligrams of venetoclax in such situations so that you reach 200. And just to reduce the complexity and the time frame when you're using a rifampicin, do not give an azole antifungal. Instead, give caspofungin or things like that.
So with Dr. Neha, who's our ID physician in our team, this is something which we have been encountering very often. And we have been thinking of ways to navigate because very often tuberculosis is not uncommon. And
Of
many
course,
of these patients sometimes develop tuberculosis while they are on HMA-VEN.
of
So if
course.
they have passed their initial induction phase, then we try to tweak the treatment and get rifampicin out and add on a different agent.
Sure.
But when they are diagnosed, like you rightly pointed out, to omit rifampicin and give the initial ATT is a little challenging.
Right. So yeah, meaning I would expect rifampicin would increase the metabolism of venetoclax, so you will end up underdosing venetoclax. So try to at least do 400, maybe then you're getting 200. Like ivosidenib, we use 600 venetoclax, then we get 400, but there is no study like that with rifampicin. Even 10 patient data from your group, if you can get some lab to do a spectrometry analysis or AUC monitoring, that would be an ideal situation and that would be a game-changing paper. We can't do that because we don't see tuberculosis here.
Right. And a lot of people have started using oral azacitidine as a substitute. So, but just to clarify, is it
We don't
recommended?
use that. Though Dr. Avandi was instrumental for the Quasar trial, it was led, I think, by Gail Robos from Cornell. We do not use oral azacitidine. We are developing, we do not use Onureg, which is an oral azacitidine, because the actual HMA is very low compared to the 75 milligram per meter square. I think it gives around 35 milligram per meter square Onureg. So we are developing other types of oral azacitidine.
So I think we have answered all the questions. You've been very patient and you've spent your morning answering a lot of relevant questions.
No
And many of
problem.
the issues pertinent to our practice in day-to-day practice, you have answered it very well. I would really
Thank
like
you.
to thank you for spending your time with us and answering each and every questions, especially many of those practical points that we really don't get to read or in it. And it can only come from someone who uses this day in and day out and has the experience with this regimen. Also,
Yeah,
something you
yeah.
pointed out, comparing clad LDAC when, and that is something I think which we can try in our practice. We have had experience with a couple of patients where cladribine based treatments have done wonderfully well, but I think that is an alternative that we have not explored much yet.
Yes,
So
and I think you guys are best suited to use that alternative because you have a good team, infectious disease pharmacists and all of them. But also important from your group would be to read out the data of patients who get in low intensity therapy and then consolidated for intensive therapy with or without transplant. That would be wonderful paper if you can work on it with Dr. Bhargav.
yeah, we do have a lot of patients because very often patients present with an infection. And as per our policy, anyone with intermediate or high risk AML, we do take them for a transplant. So we have a
Right.
good number of patients who have received azacytidine, venetoclax, and gone on to receive a transplant and who are doing fairly well at 6 months, 1 year, 2 years post-transplant. So I think that is something which we should definitely consider publishing and putting the data together.
Sure.
So once again, on behalf of Fortis Institute of Blood Disorders, I really thank you, Dr. Jayestu, for spending your time and clarifying all our questions. This was one of the most sought after most webinar that we were looking forward to because across the country, azacytidine and venetoclax has been a combination treatment that has been used and maybe misused also to a certain extent. But you have explained the topic wonderfully well and all the practical clinical points which would greatly help us in our practice, we have discussed excellently. So thank you so much.
Thank you. Thank you, Nikhil. Thank you, Dr. Bhargav.